Welcome students to Chapter 14. We're covering treatments for schizophrenia and other severe mental disorders in this chapter. And I'm happy to report to you right off that today's treatment picture varies dramatically for those suffering from serious mental illness, including patients as well as their families, caregivers, and communities, largely because of the emergence of antipsychotic drugs. Severe mental disorders are still very difficult to treat, however, with only 36% of people with schizophrenia receiving adequate care. Institutional care has evolved over time. In the 1790s, there was a move from asylums that were kind of warehousing people to large mental hospitals where there was more moral and kind treatment provided. And there were public hospitals in addition to private hospitals if people couldn't afford care. In 1955, however, there was a lot of overcrowding and understaffing, and so there was shifts to more problematic forms of treatment, such as restraints, isolation, and punishment. There were backwards where straitjackets and handcuffs could be used. People were given lobotomies to alter their behavior, which we'll talk about in a moment. And the most common pattern of decline was the social breakdown syndrome. Many people who would have been placed in psychiatric institutions in the past now actually reside in other settings such as nursing homes or prisons because there was a deinstitutionalization that took place. And mental health care is typically minimal in those kinds of settings. Just so you know, the history of brain surgery for mental disorders, it wasn't pleasant. These procedures were first performed in 1935, one of them leucotomy, where 2 holes were drilled in either side of the skull and an instrument resembling an ice pick was inserted into the brain tissue to cut or destroy the nerve. And then there was a lobotomy, where a needle was inserted through the eye socket and then rotated to destroy tissue. And many issues such as seizures, weight gain, loss of motor coordination resulted from these rather barbaric procedures. Fortunately, the antipsychotic drugs came along, and so these things were largely sidelined. In the 50s, however, there were a couple of 2 institutional approaches that emerged that were positive. Milieu therapy was one, which really just created a climate of respect and individual responsibility in institutions that resembled daily life outside the hospital, and many left the hospital at higher rates than patients receiving custodial care. Some did need sheltered aftercare. These were often combined with other community programs. Another program that was implemented was the token economy, which is the systematic use of tokens to reward behavior. It's a form of operant conditioning. So token economies did reduce psychotic and related behaviors, and they are still used in many places today, although there are some limitations to those procedures. Antipsychotic drugs started with the development of an antihistamine that would calm patients about to undergo surgery. Chlorpromazine was tested on patients subsequently with psychosis, and it was noticed that sharp symptom reduction was observed with a great calming effect. And so this drug, brand name Thorazine, was approved for sale in the U.S. as an antipsychotic. Other drugs were later developed. There was the first generation neuroleptics and then second generation antipsychotics. And these antipsychotics reduce symptoms, at least in part, by blocking excessive activity of the neurotransmitter dopamine. In terms of effectiveness, symptoms are reduced in about 70% of patients diagnosed with schizophrenia. It's more effective than any other approach used alone. And in most cases, the drugs will produce the maximum level of improvement within the first 6 months of treatment. What we call positive symptoms of schizophrenia are reduced more completely or more quickly than negative symptoms, however. There are some unwanted effects of the first generation antipsychotic drugs. The first type is the extrapyramidal effects. Parkinsonian and related symptoms result from medication-induced reductions of dopamine activity in the striatum. So there's some tremors and things. The neuroleptic malignant syndrome is a potentially fatal reaction, particularly in the elderly. And then there's something called tardive dyskinesia. These symptoms are similar to psychotic symptoms and often overlooked, and they're difficult to eliminate, but they basically involve some facial twitching, and once it has been going on for long enough, it's not possible to reverse the process. The second generation antipsychotics were better. The biological operation differed with different types of receptors being impacted in the brain. They also reduced positive and some second symptoms. They caused fewer extrapyramidal symptoms and less tardive dyskinesia as well. In terms of psychotherapy for schizophrenia, early psychotherapist treatment was rare before the antipsychotics, but today psychotherapy is more successful in schizophrenia treatment than it used to be. We use cognitive behavioral therapies and sociocultural interventions such as family therapy and social therapy. The cognitive behavioral therapies include cognitive remediation, which focuses on difficulties in attention and planning and memory. It provides increasingly more complex computer tasks until planning and social awareness tasks are reached, and it provides for moderate improvement in those kinds of executive functioning concerns. There's also avatar therapy that's been developed as a form of virtual reality, and it has been used so that people confront hallucinations in the virtual world, and that helps some patients put a face on their auditory hallucinations and deal with them better. Cognitive behavioral therapy also includes hallucination reinterpretation and acceptance. So clients are helped to view and react to their hallucinations in different ways. They may be able to identify the events and triggers better, change or challenge the inaccurate ideas of the power of the hallucinations over them. They may be able to reattribute and give more accurate interpretations. And there's education for the unpleasant sensations that happen with these experiences. New wave cognitive behavioral therapies posit that hallucinations should be accepted rather than misinterpreted or overreacted to. So just accepting problematic thoughts and helping people gain a greater sense of control because they have, kind of accepted them and set them aside to the best that they're able. It helps them become more functional and move forward in life. Family therapy is offered for persons recovering from schizophrenia and their family members that they live with, because there is a significant amount of family stress involved in living with someone with this disorder. We now have something called coordinated specialty care, which was originally called social therapy, that addresses the social and personal difficulties in clients' lives. People are given practical advice, problem-solving, decision-making, social skills training, medication management, and other things, which reduces rehospitalization. Medication management is particularly important because many people do not take their medication regularly if they have psychosis. In 1963, Congress passed the Community Mental Health Act, and this is where, because of what happened in the 1950s, people were released and treated in the community with a variety of mental health disorders that had previously been hospitalized. it stipulated that a range of mental health services should be provided, but there was inadequately quality of community care that resulted in a revolving door pattern for many patients. In terms of features of effective community care, assertive community treatment, we have coordinated services. So people who run mental health centers are supposed to provide a variety of things like medication management and medications, psychotherapy, inpatient emergency care. It's important, especially for mentally ill chemical abusers. And we also have short-term hospitalization when needed. But patients are released to aftercare programs for follow-up after they have been in the hospital. Sometimes we have partial hospitalization. If a patient needs somewhere between full hospitalization and outpatient care, there are day center programs that have supervised activities and programs to improve social skills. We also have semi-hospital or residential crisis center houses or other structures that give 24-hour nursing care. Features of effective community care include supervised residences, also halfway houses or group homes that provide shelter and supervision for those who are unable to live alone or with their families but don't require hospitalization. Usually the staff are paraprofessionals, and they are run with a Malou therapy philosophy, and they help people with schizophrenia adjust to community life. Occupational training and support is also provided. Things like paid employment results from this kind of training. Many people recovering from schizophrenia do work in sheltered workshops that have some supervision. And then vocational agencies and counselors may provide supported employment opportunities where they're monitored. Overall, though, we do have a failure of community treatment. Fewer than half of all people who need these kinds of services receive them. There are two contributing factors, which is poor coordination of services and the shortage of services. The challenges in poor coordination involve lack of communication between and within community mental health agencies, poor communication between hospitals and community health centers, and the solutions have so far involved community therapists as case managers, which does show some promise. The shortages of services include an inadequate number of community programs, so there's just not enough services, and there are economic reasons for that. Where do people with schizophrenia live? Sadly, 5% are homeless, 34% are in unsupervised living, 25% would live with family, 18% live in a halfway house. Nursing homes house about 8%, jails and prisons about 6%, and hospitals about 5%. So you might stop and think for a minute about deinstitutionalization and the community mental health movement and how it has failed people with schizophrenia and other serious mental disorders. Many people actually report feeling relieved if they're able to return to hospital life because of this. And so you might ponder, what kind of advocacy efforts you might do in the future around this issue that is serious in our profession. The promise of community treatment is in that research indicates that clients in effective programs make more improvements than those in other kinds of treatments in poor community programs. There is a worldwide push for well-coordinated treatment, and that's seen as crucial to the problem of severe mental dysfunction, and that is from the National Alliance on Mental Illness. That concludes our conversation about treatment for schizophrenia and other serious mental disorders, and I will pick this up with Chapter 15.